Hi, my name's Marcela Castillo, and the topic that I'll be discussing today is palliative care. So, during my research, I was able to find three trends that was consistent throughout all the articles. First one being the clinician and patient's legal rights. The second one being collaboration with others that have an interest in the patient. And lastly, providing methods to provide the most comfortable living for the patient. And at the end of this presentation, I will be providing my opinion. So for starters, legal rights. Clinicians have a responsibility of providing the utmost care to a patient, but can only do so to a certain extent. Everyone hopes to put patients as a one-size-fits-all scenario, but unfortunately that's not the case. So we might get a patient that is able to decide for him or herself if it's deemed that he or she is competent, but then there might be situations where the patient is unresponsive. So then the family will need to take care of all of the decision making. Regardless, a clinician is responsible of providing treatment, of providing that option for treatment, and needs to be cognizant of what the patient wants and plan treatment accordingly. Second would be collaboration. So as it says here, collaboration, a clinician needs to collaborate with the patient, family members, caregivers, nurses, nurse aides, doctors, etc. And this is very critical because we are that support system for all of them, especially then for us. So it's really imperative that we collaborate with everyone. For example, one of the articles that I read talked about how caregivers felt more positive emotional effects after having been educated by a speech pathologist and felt like they were more prepared for their role as a caregiver. Another article discussed about how collaboration with professionals and the support staff helped with avoiding any risks for disagreements or just miscommunication with the patient with dysphagia. And then I also found another article that discussed how it was imperative to be realistic with the patient about running the risks of continuing with any treatment. So that all in all, collaboration is key. So third factor was providing comfort. There was an article that discussed about first starting off with compensatory strategies. If we know that the patient's able to consume anything by mouth, then we definitely want to use that to the best of their ability. So compensatory strategies is the first way to go, and I have provided two examples here. Another article discussed how the caregivers modified the foods in order to best try to incorporate some of a sense of being for these patients. For example, they would use purees, thin liquids, honey thick liquids, and depending on their way of consumption is how they would modify the food. So, for example, a nasogastric tube, gastrostomy tube, and I hope I'm pronouncing this right, jejunostomy tube. All of these different tubes require different modifications of foods. And so caregivers would modify the culture of foods that these people provided to kind of allow them to still have a sense of themselves. And then another article discussed the use of stents with cancer patients and how that was able to alleviate some of their symptoms. And lastly, my opinion. So all clinicians understand that dysphagia is no easy task to overcome. And this is an important role because if something does not function, then it disorganizes the entire swallowing mechanism. And our focus in palliative care is to try to extend the life of the patient as much as possible and as best as possible. And so we need to value each patient's right to live a life as long as they can and to give each person a sense of hope, although the future may seem unknown. And here are my references. And thank you.